Good morning. Welcome to our second leadership lecture. One of our board members, Jerry Cook, and his family generously provided the funding for this twice-a-year event to bring in nationally known healthcare and leadership experts. Which of those are you? These are all about arming our leaders for the challenges ahead. Today we're expanding our reach to more community leaders with live streaming to 2 other campuses, Fresno Hart and to the East Medical Plaza at Community Regional. Wave, hello, hello, are you there? Hello, all right. Can you hear us? Can you hear me now? Can you hear me now? We're excited to have a personal friend of mine and the guy who pioneered the idea of putting the consumer at the center of the healthcare equation. For all of those of you who are frustrated around October, November, when you have those Humana commercials every other minute on the TV, Mike's the reason. He's going to give us an insurance industry's perspective on healthcare reform. A little bit about Mike. He was a CEO for Humana from 2000 until his retirement in 2012. He was the CEO and chairman of the board. His career actually started in Louisiana in finance. He did that for like an hour and a half and said, I can't do this. I got to run the joint. And came to California where I hooked up with him. He engineered a period of unprecedented growth for Humana. He's a really unique person. He did his whole career with one company. He was a CEO with Humana, where he ran both the hospital and the insurance product for them in different markets. And he found all the challenges that goes with that, having both the hospital and the insurance side of the business. He engineered a period of unprecedented growth for Humana. He was quadrupled its revenues and its number of employees from 15,000 to 44,000. In his final year at the helm, the company had 12 million medical plan members and ranked 79th on the Fortune 500 list of largest publicly held companies in the U.S. He was named by Businessweek and Forbes magazine as one of America's top CEOs, measured by return on shareholders' equity during a CEO tenure of the last 10 years. On a personal note, as soon as he became the CEO, I bought Humana stock, bought it at 5 and sold it at 15. Today it's 127. He continues to play a leadership role in key business organizations from 2010 to 2013 under the auspice of the World Economic Forum. He was chairman of the Workplace Wellness Alliance, a consortium of 150 global CEOs dedicated to improving employee health and well-being worldwide. He is currently chairman of the board of Zoetis. Zoetis? It's a animal pharmacological company, and a board member of AT&T. So I've already bitched at him about the, oops, sorry about that. About the AT&T stores as I tried to add a phone to one of my phone lines. He's on the board for the Fifth Third Bank and Bellarmine University in Louisville, Kentucky. He holds a BS degree from Louisiana Tech. He's a bulldog, just not a Fresno bulldog. And he got his MBA from Pepperdine. It's been a real pleasure to have Mike as a friend so many years, and give him a warm welcome, Mike McCallister.
Good morning, everyone. Thanks, Pat. It's good to see you again. It's been about a year since I gave one of these speeches, so if I'm a little rusty this morning, you'll just have to put up with it. We're going to actually move through a handful of slides relatively quickly, and we're going to go into Q&A. And frankly, you don't need to be very bashful about anything, because in all the years I've been doing this, whether it's Wall Street or providers or any other group, I've been speaking 2 or 3 times a month for 13 years. I've had every question you can think of. I've had the president call me ugly names, so we're good. No matter what you want to find out, don't be bashful. I use the healthcare reform heading here a little bit loosely. I'm not going to bore you today with a lot of slides around what's going on with healthcare reform. You read the newspaper the same and hear this news the same way I do. We've watched this roll out over the last couple of years, and so we'll touch on all that, and we can get into it as much as you want to during Q&A. But I'm going to touch on some really high-level issues relative to what we've been trying to do with healthcare reform. I was one of the first ones to come out in 2000, especially for my industry, and say that healthcare was a complete train wreck. Health insurance was awful. The delivery system was broken. There wasn't any information. Consumers were powerless. Costs were out of control, and we had to change it. and basically argued that the consumer was going to have to be where the power center was in all this to fix it, because this is an economy with 70% control held by consumers. And in this economy, bad services and bad products get crushed instantly by the public. And yet in healthcare, none of that ever occurs. There's no power at the level of the consumer. So in 2000, we started talking about that. I was a bit of an outcast in my own industry because that's not the way the industry thought about things at that time. So we've come a long way, and I'll touch on all that as we go. As Pat said, I do come from the background of running hospitals for a long time. I was a hospital CEO for 20-some years. Humana had an interesting history, so I've seen an awful lot of things happen in that period of time. I was with the same company for 39 years. I signed one of the first capitated HMO Medicare contracts in Orange County, California, back in the early 80s when they were just starting. Lost our shirt, did awful, good lesson. At one time, Humana was the largest entity in the US trying to integrate delivery systems and insurance. At one time, we had huge staff model clinics in markets across the country, had hundreds and hundreds and hundreds of physicians under employment. By 1997, we had none. At one time, we ran the largest number of outpatient doctor office clinics in the country. That didn't work out. So you go through all of this. We're one of the first players in Medicare. And as you think about what we've gone through over the last 25, 30 years, you're going to find out today, and I'm going to talk about this, a lot of this stuff is not new. There's almost no new ideas. There's some new things going on, and they have a different twist, but it's not anything really fundamentally different. So let's go back to healthcare reform. What was the goal? Remember this, because this is important to remember because the conversation is already getting a little silly. The goal was two things: universal coverage and get cost under control. That was it. What you're going to find over the next couple of years, and you're already starting to hear it, is a redefinition of what success is. Because this was supposed to be success. But if you're an opponent of what's gone on, you're going to have a view of this. If you're a supporter, you're going to have a view of this, and both of you are going to be able to use the same slides to make your point. So at 100,000 feet, this is what's going to happen. And this is the CBO, this is the government's own information. So you see the number of uninsured right here, dropping from here to here. The bad news is that in 2021, we're still going to have 30 million people uninsured. Now, a lot of folks are going to say, isn't this great? And that's a wonderful success. And those are going to be the supporters that say, this is good, look what we've done. And there's nothing wrong with that. That is success at some level. It's not necessarily hitting the target that was set when we started all this. But then this is a little disappointing, because what was the other thing? We're going to get costs under control. Here's where costs are going. So I don't see much of a change in that line. And this comes down. So basically what we've done here is we have reorganized and changed the entire system of financing and eventually delivery of care, I think, in order to accomplish this and nothing else. Now that's a fine achievement, so you can decide whether that's a win or a loss or what that is, but that's where we are today. That's what's happening. So I remember being in Washington a few years ago, in 2009, and we were at a place having some cocktails with some of our staff in Washington, and I wrote on a napkin, which is some of my best work occurs in these places, by the way, what I thought was going to happen in healthcare reform. This is before it was ever passed. And I wrote on that: Medicaid expansion, elimination of pre-existing conditions, taxes. That's what we have today. That's what's been implemented, and that's sort of what, because most everything else has either been delayed, put off, it's gone, individual mandates kind of disappeared. The one I didn't count on was the ACOs, and I didn't count on the subsidy program that was part of this whole thing. So I missed a few, but basically, this is what we have today. This is where the difference really is occurring. I mean, there's been a lot of people in that previous slide. A lot of this is actually Medicaid expansion. In about half the states in the country, Medicaid has been expanded, with the federal government paying almost all of the cost of that for a while. And so you get a lot of politics buzzing around that. And you've got some saying, well, we don't trust them, so they'll pay for it for a while, and then they're going to leave us holding the bag somewhere down the road. So that's kind of what's cooking there. But essentially, we have Medicaid expansion. That is actually working. A guaranteed issue. If you go back to the public polling prior to healthcare reform, the number one thing that people were worried about was falling through the cracks, having a pre-existing condition, and not being able to get coverage. It scared everyone, whether they had insurance or not, because everybody could think of a day where maybe they lost their job, and they're 47 years old, they got a heart condition, and they can't get insurance. So everybody was scared spitless over this concept. So it was a given that when this was all settled, this was going to be taken care of. Now, this was linked to the individual mandate, because if you're on the insurance side of the business, there's no way you can have guaranteed issue without everybody participating, because otherwise your risk pool deteriorates and the whole thing falls apart. So what we don't know yet is how this is going to play out. It's still very, very early on this concept right here. And there were 5 states where this actually existed, the idea of guarantee issue, no underwriting, before. And in each one of those states, the cost of health insurance for individuals buying in those markets was about 5 times higher, which is a direct result of the risk pool deterioration associated with letting somebody buy coverage when they're sick. Entitlement expansion through subsidies, that was something that I don't think anybody really thought was going to happen to the degree that it did. But this is actually a huge entitlement expansion that we're going to see how play out over a number of decades now. And then ACOs, ACOs, that's 3 letters. You could easily just turn those into HMO and you got the same thing, because that's what they are at the end of the day. But this has been pushed big time, and we've seen a huge interest across the country in the development of ACOs. We'll see how that plays out. What's different? Again, the concept of organizing care and changing the financial model and getting people theoretically aligned and incentivized to work in the same direction is not new. That's been around for a very long time. One of the weaknesses of the managed care and HMO model historically was not a lot of connectivity, not a lot of actionable information, not a lot of real-time ability to adjust, understand what's going on with patients and change things, not a strong ability to get ahead, and the incentives were not always aligned perfectly. So what's new here? What may change the game this time? Because in large part, the concept of integrated care and managed care was not successful in most of the country. But what is different today is some tools. We now have much better IT. We have connectivity. We have free and fast movement of information. We have mobile technology. We have social networks. We have a lot of things that can lend an awful lot of power to this concept of getting patients in a better place, keeping them out of the treatment systems, keeping them at home, monitoring their health, and that sort of thing. I can actually see a day where, and we're already starting to see this with nanotechnology and things, where they can put things in clothing and things where you can monitor people's health from afar. There was something in USA Today yesterday, I think, where they're developing a contact lens to be used with diabetics that can check blood sugar levels on real time. So you can see a day where somebody's going to walk into a room and it's going to look like NORAD with screens all over the walls, and somebody's going to sit down, could be a nurse, could be a doctor, someone, and they're going to be keeping up with 50,000 diabetics with a smart system built behind it, pulling from big data, which basically says, okay, these are the 25 people today that really need some attention. And so what you're talking about when you describe things like this is huge productivity gains that can come from this sort of thing. So we'll see how that helps us, but that's what's really new. The principles around organizing and all that are not new, but the tools are definitely new and very good. It does set up an opportunity for payers, providers, everyone to sort of get on the same page, because I use words the business community uses, a lot of people in healthcare don't use them, such as productivity. The question is, as we get higher productivity in taking care of people and treating people and all those sort of things, who's going to benefit from that productivity gain? And if it's a win-lose situation among the major participants, it's not going to be a very healthy environment, because that's where we've been for 25 years, and how do we like that? It's not very good. But there is productivity to be gained, because there is huge waste in the healthcare system, and we can argue how much that is. Some would argue it's 10%, some would argue it's 40%. It doesn't really matter, it's a very, very big number. So as we take that out, as we get higher productivity, who's going to gain? And there's an incredible opportunity for the major participants in this whole thing to actually work together, and for everybody to have a stake in all that. This is the evolution of old fee-for-service on the left, all the way up to integrated delivery systems across the country right now. There is a huge effort to build integrated systems. Hospital systems have been purchasing doctors' practices, organizing them into entities. Some know what they're doing, some are totally clueless. So we'll see how that plays out. That's been done before too. There was an era when doctor practices were being bought probably in the early 90s, left and right. That didn't work very well, but now we're doing it again. So we'll see how it works this time. If it comes into these new economic models with a different agenda, there's a good chance that it's going to be very, very productive. This is the slide that should scare everyone. Basically, this is a geographic chart going from white all the way over to dark red, and as it goes darker red, it basically shows the percentage of people in these states that have a BMI over 30. Now, BMI is not a perfect measure, but it's a really, really strong indicator, because if you're us and you look at the data, and we have the ability to actually compare ages and body mass indexes against medical spending and this sort of thing on huge databases, you'll find The people with a body mass over 30 spend a huge percentage of the total dollars. And people with a body mass index under 25 spend almost no money in healthcare. So there is a direct correlation here. And basically it says that within a single generation, because the top left map is 1990, the bottom one is 2010, so you go left, right, down. Look what's happened in this country. So you can reform the healthcare model all you want. You can reform health insurance. You can do all these sort of things. But if we don't get at this, none of it's going to matter because we're going to be overwhelmed. This will be one of the major metrics that's going to drive what's going to happen to us in the future. This one's quite scary. Well, what comes with that? Chronic illnesses. I mean, so we're fatter, we're sicker, and you can see what's happening here. 50% of middle-aged adults, 69% of the elderly have one or more chronic conditions. We're one of the biggest Medicare players. We've had an opportunity to look at seniors for a very long time. And we are all going to have chronic illnesses as you get older. I don't care. It really helps to take care of yourself, but eventually it's going to catch up to us no matter what you do. And here's the data that would tell you that. We're also getting older, so we're fatter, we're sicker, and we're older. And these things do tend to run together. So you can see what's happening with age-ins into Medicare. So, and Medicare is the single biggest budgetary problem that the United States has. And the conversation in Washington, sometimes you think, don't these people realize what's going on? Because if you listen to the rhetoric, you wonder, either they're clueless or they choose to be clueless. So why are we like this? Why do we have health issues? You could put up any number of slides to walk through what people do, but if you took these 5 things, what percentage of Americans do this? Exercise 20 minutes at least 3 times a week, don't smoke, eat fruit and vegetables, wear seatbelts, and are at their proper BMI. The answer is 3%. So we're not really taking care of ourselves very well. So that's why I think you're also beginning to hear so much around wellness and incentive programs and little gadgets and tools. I've got a Fitbit right here in my pocket. I mean, this stuff is everywhere. Some of you may do these sort of things. It's all about figuring out how to sort of change this, because that's the long-term solution, frankly, to the big picture problem. And none of that has anything to do with healthcare reform, 0. So, 55% of what goes on from a healthcare perspective and the cost is tied to our own behaviors, things that we actually do. That's not a system matter, that's not a financing matter. It's how we do things, how we live our lives. And basically, we're driving these healthcare costs. And all these things we're doing in terms of changing the system don't have a lot to do with this. It's up to us and what it's going to take to get behavior modification. Now, I'm going to switch gears here slightly and talk about Medicare, for example, for a few minutes, because Medicare is such a great place to study and learn and figure out what to do in healthcare, because the volumes are high, people use a lot of the system. And the question is, if Medicare has a $42 trillion shortfall problem, what are we going to do about it as a country? And I would argue, and people say, well, it's in your self-interest to do that. Of course it is. I'm big in the Medicare Advantage business. I think the private sector's effort in Medicare Advantage has been a spectacular success on almost every level. Costs are under control, better there. The quality measures are good. Satisfaction levels are very high among the populations in these programs. And a lot of people have figured out how, in fact, to do exactly what I described earlier, gain some productivity in taking care of seniors. Some of the things we've learned, because we're paid to do it, if you think about the economic model, if you're getting a single payment at the beginning of the month to take care of somebody, if you're a critic of the program, you'd say, well, you already have the money, you're not going to take care of them. Well, okay, maybe. The other argument would be, I already have the money, so if I figure out how to get them in a better health status and to stay in their home and be healthy, we all win. They win and we win. So you can pick your poison on that. But at the end of the day, we've learned a lot about what it takes to keep people staying at home, staying on their medications. Medicare Advantage drug adherence is very good. You can go through every metric. This thing works and has been highly, highly successful. So, the question is, why aren't we doing more of it? Well, as long as we can stay out of the way of this program, it's going to continue to get bigger, because this is the growth of it. Just since 2005, we've gone from 5 to 15 million seniors voluntarily signing up into this program. This is another reason they don't spend as much money here, because as the productivity is gained, who wins? You basically can take down what they have to spend in the healthcare system, And they end up with a better financial deal, they end up with better healthcare results, and everybody wins. So you can see what the out-of-pocket spending looks like in Medicare Advantage versus original Medicare. Out-of-pocket, if they're in an HMO, is probably going to be about $140-some a year. If they're in one of those Medicare Advantage PPOs, it's going to be this, and this is the out-of-pocket spending in traditional Medicare. So there's a huge economic advantage. Seniors are very focused on this. They do, and you all have parents, you probably know this as well as I do. They pay attention to this stuff, and in fact, they change their behavior and make their choices accordingly. So those are all just teasers. We have some significant time now to get into anything you want to. So at the end of the day, what I would basically argue is healthcare reform is interesting, depending on where you sit. It's either good or bad. It's helped a lot of people. It's hurt a lot of people. If you were 47 years old and had a heart condition and wanted to buy insurance, you're a winner in all this. If you're lower income and you're getting a subsidy, you're probably a winner in all this. If you're 28 years old and healthy, you just got hammered. And you can just go around and figure out who wins and loses, but there's all sorts of, and any major policy initiative is going to produce those kind of results all over the map. So, I'm not going to get up here and disparage or support any of this stuff. It's just different today. It is what it is, and we're adjusting to it as an industry, and we'll keep moving. Again, I don't think it attacks some of the basic underlying issues, and I don't think that the new health care bill does anything at the end of the day really to do anything about the rising cost question, but for the potential that ACOs may represent. That is the one piece of it where we may see some cost implications over the long haul. I will predict that a lot of these ACOs will fail because at the end of the day, they're fundamentally small insurance companies is what they are. And that's not new. That's been popping up all over the country for a long time. We used to buy those generally from hospital systems that would basically at some point decide strategically, oh my goodness, this is not a real core business for us. And they'd call us and say, please take this away. So we'll see if that plays out again. I don't know. I think that's uncertain at this point, but that has the potential to do something about cost. The rest of it is more about changing the way people are treated inside the system and this sort of thing. So with that, we can move to questions, and you can touch on virtually anything you'd like. Who wants to start?
Sir, for the states that chose not to expand Medicaid, what's the outcome for them? Such as Texas.
Well, the question is, for the states that opted not to expand Medicaid, I mean, the obvious is they're not going to have as many people in the program. Some of that, you can argue whether that's all politically driven or not. I mean, there is a history of the government, the federal government, unloading costs and things on states. So there's a reason to be a little skeptical that at the end of the day, that these new Medicaid folks are going to be paid for 100% by the federal government forever. We all know the budget problems in Washington, so there'll be pressure to do something. So, whether it's politically driven in all these places or not, I don't know. At the end of the day, though, the thing that's stopping folks from doing it is not trusting that at the end of the day, the feds will fund the way they do in the beginning. So, yes.
Oh boy, and I have to stand up. So hospitals by and large are still paid the old-fashioned way, fee for service. The push is to go to value-based purchasing. Do you have any advice on how to best weather that transition period?
Yeah, I'm not a huge believer in value-based purchasing, so I'll just put that out there to start with. That's generally not the way contracts are driven and not way services are bought between payers and provider systems. Because this facility may be the greatest hospital in the world for neurosurgery, but it may be an average on 10 other services. But if the hospitals tend to be paid, hospitals in particular tend to be paid based on reputational things driven by something. So you would want to go buy that because it's the best, whatever that may be. But in doing so, you end up buying everything else at the same time. So you're always buying this stuff as a package. You're never buying it individually as a service. And so there's a lot of proponents out there and some real big thinkers around this that say, if we could just get the best of breed in all these services and get people to use them, wouldn't that be great? The answer is, of course it would be. But the economic model isn't built such to really drive that aggressively. A perfect example, Cleveland Clinic, Mayo Clinic, some of these places are really big into people traveling in and taking and receiving services and this sort of thing. And they would argue, we do the best heart care in the U.S. Send us all of your people. Well, that's interesting, but it's kind of hard to do that because first of all, the economic model is not such that that's going to make a huge difference because most people have a deductible or a cap out of pocket that's not so big that they're willing to go travel and go all the way up there. And their local providers are arguing, and that's interesting, but we do wonderful quality work right here too. So you don't see that sweep in the country, and that's value purchasing essentially. So we'll see. If you go to all the institutions around the U.S., some of them have incredible, great reputations for certain things, but almost none of them have reputations for being great at everything. So, none. I've never met one. What else? Yeah. There's a microphone right over here.
Good morning, Mr. McCallister, David Lillybridge. A question about the ACO, and you answered, it's kind of a two-part question, but I think you kind of caught the last part of it. I hadn't really correlated ACO to HMO, so I think that's interesting. Is that really, in your mind, the same? And then the second thing you kind of touched on was, I was going to ask, do you see the model expanding in the U.S.? You kind of said you see the smaller ones failing, but just thoughts on that.
Well, I would argue the ACO is an HMO. We can call it, but I mean, think about what is it structured to do? It's structured to take a different payment methodology, generally a fixed amount of money, and then provide services, inside of that, and to get everybody aligned to do the best and that sort of thing. I mean, it's nothing new there necessarily. There's some different rules regulatorily around it that are allowing some of these things to crop up in ways that we would never be allowed to do it as an insurance company. But but like I said, I've never seen more excitement about anything because if you're a consultant working and helping people figure out ACOs, you've been very, very busy. It's been a great business for a while. So we'll see how it plays out. I mean, again, some things have changed. In most communities, hospital systems have been acquiring doctor practices, so there's automatically some level of alignment just because of that didn't exist when these HMOs were growing up in the late 80s and 90s. So we'll see if that has any real significant difference. But it's all over. It's very hyped at this point, and we'll see how it plays out. I'm skeptical a lot because we've been there before and we've seen this. And at the end of the day, it ultimately gets down to the doctors. And can the doctors be aligned? And is there enough data support? And can they be, guided and helped and supported and whatever to make them, successful here? And that's the part that's been tough in the past. And we'll see how that happens now. And I don't think a direct employment relationship automatically produces success. Generally, you see about a 30% drop in productivity in physicians when their practice gets acquired, because they used to work their tail off. Now they're working for somebody else. Like, I'm going to play golf today. So, yes.
Great presentation, Mr. McCallister. This is John Taylor. Do you concur with the feelings of some industry leaders, hospital association types, that perhaps as early as 2020 we're going to have a single-payer system in this country?
I don't know. I would argue that we're on a slippery slope to that. Because I think, let's go back to the healthcare reform for a minute. There's some good things, there's some bad things, whatever. Shoes are going to continue to fall relative to people understanding what happened here. So I can tell you from an insurance perspective, let's take the exchanges. A number of companies got very big in that, some stayed out of it altogether, but at the end of the day, the products that were generally designed to go inside of those offerings that are on the exchanges are very narrow in provider scope, very. So you can have some major city with 20 hospitals and there'll be 2 that are part of a plan, and then some subset of the physician community. Many times it'll be 20% of what it used to be. People haven't really figured that out yet. I don't know how big of a deal that is, but if those of us that have been around a while, that lived through all this when HMOs got big back in the late 80s and 90s, they were exactly in this spot. People jumped into them, what happened? Pretty soon, the pushback relative to the structural side of the thing started occurring, and all of that melted down. That's still ahead of us for all these folks that are now in these programs. Things like that are going to continue to happen. I'm a predictor that the risk pools for this is going to be negative, but we'll see. That's data still to be delivered. So I'm concerned that there's going to be a public pushback at some point after all of this movement and all this effort and all this noise and all this sort of thing, and it's not going to solve problems enough to keep the public from finally saying, okay, we give up. Let's just go to that. It's simple. We got it, but we don't want to put up with this. I don't know if we're going to end up there or not. I think we've got one foot on a very slippery slope right now. So, yes.
What's your opinion on the future of Kaiser?
Well, I don't know. You'll have to call them. I think. I used to always argue that Kaiser had the perfect model. I still do. And they've had a hard time taking that model around the rest of the country for lots of reasons. But they are probably one of the better, examples of a fully integrated environment with electronic medical records, good data systems, and that sort of thing. So I've always been impressed with them. So I think they're going to be around as long as they want to be, and I think they're going to be successful to a degree. I don't know if they'll figure out how to get out of the footprint they've been in for a long time, but they're a very good model. And they do actually very good work. And the satisfaction rates of their customers are actually quite high. Yep.
Question on the MA growth, the Medicare Advantage growth. I know a lot of the Medicare population is transitioning to that. How are the plans doing financially? And the reason I ask is just the long-term financial stability of the MA plans and how the plans are managing it.
That's a big question for investors because Wall Street thinks healthcare reform has been wonderful for the plans. You can look at they think it's a positive that all these new customers are going to come in now. It could turn out that way. Again, we'll see. When it comes to Medicare Advantage, I was very disappointed how Medicare Advantage was treated in the whole business of this reform. Not that the payment rates came down for the programs, because in some cases, they were really pretty high. That was not the issue. But when they ultimately put taxes on revenue in order to do this, either it was an intentional act or it was a mistake, or I don't know. But basically the taxes, or there's excise taxes on insurance products in the US now, but only on fully insured products. So I'm sure Community Health Systems is self-funded. There's no taxes being attached to this revenue as a premium concept. But for private sector Medicaid, which is a fully insured product, there's taxes on that. Medicare Advantage, which is a fully insured private, taxed. Individual coverage, fully insured, taxed. Small businesses buy real insurance, taxed. Large corporations, no tax. I mean, they just absolutely hammered the MA program through taxes, not so much the payment cuts. So, the concept there is, okay, fine, now we'll have to figure out how to, build that in and pass some of it on to the extent that that's possible and that sort of thing. So I think MA is a very, very strong program and is going to be around a very long time. So all of this is just painful and difficult, and it's been to the detriment of seniors to some extent because a lot of this going on flows down to them. But the program itself, I think, is the answer to what they have to do in Washington, frankly. They need to get somebody involved in driving productivity, and this is the best way to do it. It already exists. It's already huge. Let's just ride that horse. So I think it's going to be around a long time, and everything that's going on today is manageable but painful. So huge Medicare cuts. We're part of paying for all that. What else? Back here.
To what extent do you think the supply side is driving the economic increases in the cost of providing health care? You alluded earlier to the demand side. We're getting older and bigger. What about the costs of running this business? And
that's a tricky question, given all the construction you have going on around here. I choose not to answer. Well, on this one, I'm a real cynic. I'm one of those that's in the category of if you build a closet, no matter how big it is, it tends to get filled up. So you can go around the country, and there's actually a fair amount of data that will show that the capacity will drive volume. And it just is. The incentives are all wrong, so if it's easy, if it's simple, depending on who owns things can make a difference in terms of how much things are used. So when I talk about sort of waste and inefficiency, it kind of falls in that bucket. And the variation around this country in terms of how people are taken care of is remarkable. I mean, for example, you got a $48 trillion problem in Medicare, for example. If everybody in the country that was over 65 actually lived and got health care in Utah, there wouldn't be a $48 trillion problem. If they all were living in South Florida, the whole government would be broke in about 24 hours. I mean, so it's just unbelievable, the variation. Not only in the economics, but just the way, I can remember being a hospital CEO for years, sitting in medical staff meetings where the doctors would argue, well, we have a local standard of practice. I used to think as a layman, are you kidding me? What's the difference in taking an appendix out in Chicago versus Corpus Christi? Give me a break. But that was the theory we operated on for many, many years. And so huge variation in terms of actual care, real slow rollout of new developments and new standards of care. Used to take about 10 years. I think it's a little shorter now. And then capacity can drive volume for a number of reasons. So those are the kind of things that at the end of the day you're trying to get to when you start organizing and thinking ahead and having data and having protocols and that sort of thing. And nobody wants to do necessarily just textbook medicine all the time, but there's always room for judgment, of course. But we need more textbook medicine than we have today, I can tell you that. So.
We don't have any more questions here in this room. We're going to go downtown to East Medical Plaza for questions.
Uh-oh, can't hear you.
We can't hear you.
Can you hear me now?
Yes?
Yes.
Okay. So it seems like a component of the success that you're expecting with healthcare reform is going to be resting on the premise that the newly insured are now motivated to take better care of themselves. How likely do you think that is that it's actually going to happen, and what sort of advice would you give to the healthcare networks or ACOs dealing with that issue?
Well, I mean, depends on what you mean by take care of themselves. I think the fact that some of these folks now have coverage for the first time, they maybe end up in doctor's offices and doing things that most of us would do routinely more often. That's possible. I don't know if the fundamental behavior things we talked about earlier are going to be affected whatsoever by insurance coverage. So that part I don't think is necessarily addressed here at all. But I think it's likely that we're going to see people that'll they'll go for routine care more frequently and quicker because they have some level of coverage versus what they had before. So I think that's generally a positive thing relative to that. We'll see. I mean, you all may even have a better judgment, be a better judge of that than me based on what you're seeing in your emergency rooms and all sorts of things, because I'm sure we have, some newly insured people in this community. So, we'll have to wait and see how that's going to ultimately play out. But I think there's a very good chance people will take better care of themselves if there's some economic, protection when they do it. So, but it doesn't address behavior change at all. And what was the ACO part of that? I missed it.
Do you have any advice that you would give to networks or ACOs dealing with these newly insured on that topic?
Well, I give advice to the ACOs in a different direction altogether. It has nothing to do with the newly insured. I always tell them start with Medicare. If you go back to Medicare HMOs in California in 1980, all of them really were the drivers of pushing integrated doctor groups. So if you look at some of these big doctor groups that are around this, and this is a state was a pretty good example of this, it all began with Medicare HMOs. Then it ultimately transferred over into the commercial business later, once they kind of got their act together and knew what they were up to, because they could have never started on the commercial side. There's not enough upside to make the whole thing, in my opinion, work well. You got to start where you got to go fish where the fish are. And Medicare is where the high volumes are and where a lot of the social volume occurs and this sort of thing, not in the commercial sector. And one of the mistakes I think ACOs are making today is a lot of them are starting with a commercial mindset. And I think they're not going to like that when they get into it and start figuring out there's not enough upside here to really make this work. The upside, in my opinion, is on Medicare. So that would be my biggest and first piece of advice to them. Start with Medicare.
Any other questions from downtown?
No further questions.
Okay, then let's go over to Fresno Heart.
Hi, this is Wanda. Can you hear me?
Yes.
Okay. I have a question about employment of physicians. California is one of 5 states that doesn't allow for employment of physicians. So how do you think that's going to work with some of the things in healthcare reform and how we need to partner with physicians on, population management and things like that? Will that be a barrier for states like California to not be able to employ physicians?
I'm not sure it's going to make that much difference one way or another. I think the economic models can be built to get you to the same place without necessarily having to have an employment relationship. It might make it easier if you're the system CEO to deal with doctors, if you can at some point tell them, hey, look, you work for me, we're going to go do this. Maybe that makes it easier, but at the end of the day, I think economic models can be built to get you to the same point without actually having to have an employment environment. We as Humana, we have a mixed model. We have hundreds and, at this point we got several thousand doctors that are employed, but we also do business with 400,000 on various other terms too. So to me, I don't think you have to draw a hard line in the sand on that one way or the other. You have a question, Patrick?
You know I do.
Oh, here we got one here. Okay, go ahead.
Say what?
Me?
Oh, go ahead.
Okay, I think that the estimated cost of obesity-related problems is about 10% of the healthcare cost. How do you propose dealing with this epidemic?
Yeah. Did everybody hear the questions about obesity? I don't know if that 10% is right or wrong. I don't know the number. I know it's big. And we know where it's going to lead. It's going to lead into the whole diabetic thing and everything that goes with that. But, you know, no one has solved that problem. I meet with pharma people all the time. And I said that the next great giant drug in this country is going to be related to obesity. If anybody finds one that works, it's going to be unbelievable in terms of being a product. And they haven't found it yet. They've struggled with it. And so it's not necessarily going to be a pharma solution. No one has figured out how to get necessarily people motivated to take care of themselves, despite all the commercials and all that. I mean, think about the industry around, you know, machines and gadgets and gizmos and diets, and I mean, it's unbelievable how much money is being spent on this subject. And there's no evidence that there's been much of a difference made so far. And it's bad news is that the rest of the world is following us quite closely. I mean, if you look at what's going on in places like China and the emerging markets and other places, the same thing is happening. They're just a decade or two behind us in terms of what's happening. They're adopting our food, our lifestyles, and they're ended up going down the same exact path. So we're like the canary in the mine at this point for the whole global healthcare world, frankly. I don't know if anybody has that answer. I think there's a huge opportunity in all that. I think it is tied to incentives. I think it's going to be helpful. I mean, everybody in this room, I'm sure, has a frequent flyer card for an airline in your pocket. And no one has ever been able to deny the fact that it doesn't change their behavior. It does. And if you're used to flying Delta and getting your points, you will work your way onto a Delta flight, sometimes at your own inconvenience, to get your points. And you can look across the entire economy. We are all motivated by things. And people have figured out how to manipulate us. I mean, when you walk through a grocery store, those things on those counters and where they are and what color they are is a function of research around how we behave. So we're being manipulated constantly. You could argue whether that's good or bad for us, but it happens and we can be manipulated. That's a terrible word, but the question is, how could you take that concept and deliver it into the health space to get people to actually pay attention and want to change their behavior and do it? So things like this, or these little gadgets are an early effort to do this, try to figure out, and this is like having your mother follow you around, by the way, if you've never had one of these on. And you literally will walk up and down, things because you'll take the extra 20 steps because, well, maybe I can get a few more steps. So, we will do things for rewards and incentives and all sorts of things in the rest of our lives constantly. You've never seen any of that in healthcare, and you've never seen any of that around health status. And so, you're seeing companies now, this wellness thing that with the Davos crowd was all around how could employers start driving the subject. How could employers play a role in getting people to start taking care of themselves? Because at least there's a relationship there, and potentially there's a mutual concern, because there's a split cost between you and your employer around your healthcare cost. So employers have begun to step up. There's a fair amount of cynicism out there among employers around whether any of this works. So investing huge sums of money is sometimes difficult for them, but they're starting to get there. And I can tell you, inside of our own company, we were huge on the wellness side and incentive programs and measurements and keeping up with your, we wouldn't let people have insurance at Humana unless they had a biometric screening. And some people thought that was a huge incursion into their privacy, and how dare you do this, and isn't this awful? But at the end of the day, it's amazing how many people have no clue what their blood pressure is and all these other things until there's somebody forces them to sit in a chair and get it checked. And it's like, whoa, it's remarkable what happens. So, employers can push this agenda. So there's a chance there for a little bit of momentum, I think, at some point. They can build benefit structures around things. So for example, we had 50,000 employees. We had thousands of diabetics employed there. We do. It's a big enough population. We have everything in there. And so the question is, okay, how do you get the diabetics to take care of themselves? Well, you can set up benefit structures that says if there's an organized program to help with diabetics or diabetes, and you're participating, your benefits look like this. If you decide to sit on the outside and not participate, your benefits look like that. So you can start building those kind of things. Carrots, sticks, digital measurements, lots of different things that can hopefully, we'll find a methodology somewhere in all this that we can get people to start changing the way they think about all this. But it's difficult. It's really hard because of the types of things we're confronted with. And how many fast food restaurants are within 5 miles of here? There's probably 50. It's easy, it's fast, it's relatively inexpensive. That's the kind of thing that's hard to fight against. And even in the schools, you have a hard time changing cafeteria menus and this sort of thing. It's difficult. Kids are used to eating pizza and drinking soda. You take them to school, you say, okay, we're going to eat salads for lunch. First of all, they won't eat it. And two, they don't eat that way when they're at home, so you may be wasting your time there. So this is hard work to get people to adjust and change and do things differently, but no one yet has found a solution. But there's a lot of work going into it. Anything else back here? Yep.
Yeah, where in the world is there a high-functioning, cost-containing national healthcare system, single payer or not?
Nowhere. It doesn't exist. If you look at the rest of the systems around the world, they are less expensive on a per head basis, but they have the same cost problems. We spent several years in the UK working with the NHS, and the NHS is one of the models globally of a centralized single payer system. And what are their problems? Costs are rising too fast. I mean, I can tick them all off and I could put US at the top and you'd have the same thing. Now they've got a different structure and they've got more control. I mean, they tell people at a certain age you can't have certain services. They actually do that sort of thing. They tell pharma companies, what they'll pay and what they won't pay, and they won't put them on the list even if the drug is wonderful. I mean, there's a lot more direct control and government involvement in some of the basic structural things. But when it comes to the health of the population, driving higher productivity, getting healthcare costs under control, they have the same issues we do. There's just a different level. And people are paid differently. I've got a colleague of mine that used to walk around with about a 10-slide PowerPoint thing, basically making the argument that the biggest difference between healthcare costs in Europe and the US is the price of services. Price, period, nothing else. A knee surgery in Paris is $1,100, and here it's $3,900. So we can argue about why that is, or whether it's right or wrong, but once you've reset the level, the cost increases are causing trouble for everybody. Anything else?
Anything else? Any other questions?
Let me just close by saying I really appreciate the opportunity to come out and thank you. Great, those are all great questions. I appreciate it. None of them, nobody really went after me, so this was an easy one. So, and thank you for that.
Well, before you leave, you've had the opportunity to spend time with, I guess, like our last 3 presidents at some level.
Yeah.
Any thoughts, stories, anything you'd like to?
Well, I can't tell some of them. So, no, it's been. I spent a lot of time in Washington with the various political factions, and it can be rewarding and it can also be awful depending on what you're talking about and who you're talking to. I found most significant leaders of all kinds. Everybody's heart is generally in the right place. How to go about doing things can be widely divergent. It's been fascinating. When it comes to healthcare, it's not the best subject when you walk around Washington because there's a lot of folks there that really don't know much about it, and some that profess that they do not. And it was really awful as the health reform bills were being written, and there were several of them underway, at any particular moment in different places. I remember sitting in one significant congressman's office who was in the process of writing a bill with somebody else, with the staff, and because to go back to this universal coverage subject, I said, what are you all writing into this relative to the illegal immigrants in the country? Because there's 12 million of them. Well, we're not doing anything with that. I said, well, okay, so then by definition, we know we're not covering everybody. We're at least 12 million in the hole, no matter what else goes on here, because you're ignoring that population. Yes. So that's the kind of things that happen, and that's kind of frustrating. When you get into the meetings with the presidents, things tend to stay at a pretty high level. The Bush administration was really big supporters of the concept of HSAs, high deductible health plans, consumer empowerment, all that sort of thing. They were very, very significantly supportive of that. There's less of that today in this world, so things change a little bit as people change. But on balance, it's hard to get things done up there, and we hear about that on the news constantly. But it's as my son would say, it's a true fact. I don't know what other kind of facts there are, but this one's true. So. It's fascinating, and there's reason to be hopeful, but it's going to be hard. That's all I would say. And if we change who's in the White House or wherever, the subject matter doesn't change. The issues are the same. Answers to how we might address that will potentially be different. So I think this bill we have, for example, with different folks in charge, would have never looked like this. It would have been totally different.
Any other questions? Well, Mike, thanks for a great
Well,
morning.
appreciate it very much. Good seeing you all.
Appreciate the
Thank you.
information. And I'd just like to give a shout out to Shannon Kassir and Carla Milton who put this together, and great job. Please make sure you fill out your surveys, and Mike's going to be around for a few minutes if you want to just stop out here and talk to him and ask some questions to him personally. Thank you.